Hello, welcome back here for the third session here in the complex room, day one of the GIEQs Congress, and the session is entitled There is Always Another Way, Biliopancreatic Interventions in the Altered Anatomy, a very hot topic in HPB disease, I would say, and I'm very happy that we have some real experts in this field brought together here in this room. Rogier Voermans from Amsterdam, which I already presented. Then we have Professor Massimiliano Mottignani, also an expert in the field. Christophe Snauwaert, I will introduce him. He is an, I would say, all-round interventional endoscopist working in St. Jan's Hospital in Bruges, in Belgium. Welcome, Christophe. And then we have Enrique Perez Cuadrado Robles, again, also an expert in the field. Thank you for joining here in this room for this session. The session objectives are to recognize the technical challenges of ERCP after a pancreaticoduodenectomy, to compare the approaches that we have available for the Roux-en-Y gastric bypass patients, device-assisted ERCP, EOS-guided access, or surgical alternatives, to identify strategies for interventions in other altered anatomies, so non-Roux-en-Y gastric bypass and non-Whipple patients, Bilrow 2, hepaticojejunostomy, for example, and to evaluate the advantages, the risks, and the limitations of each of these endoscopic techniques in altered anatomy. And then to apply flexible, tailored problem solving during live biliopancreatic interventions, and we have a very nice case that will be done today. The quiz question: which of the following statements related to use of EOS-guided biliary interventions in patients with altered anatomy is correct? A. The edge procedure is typically performed after total gastrectomy. B. Adverse events are less severe as compared to enteroscopy-assisted ERCP. C. They can theoretically be applied in all altered anatomies. D. They do not require specialized expertise or equipment. And E. They are always much cheaper than conventional techniques. And with this, I would like to start the session with a first lecture, which will be given by Professor Massimiliano Mottignani on post-pancreaticoduodenectomy. Floor is yours.
Thank you. Thank you. Dear colleagues, dear friends, good morning. I would like, first of all, to thank Peter Hendricks for this kind invitation. My topic is a strong point in my clinical practice. So these are the more frequent indications to perform an endotherapeutic approach in the setting of PD, mostly represented by the pancreatic fistula, and the chronic complication has a stricture of both biliary and pancreatic anastomosis. Doesn't work? Yes. I jump. Okay, now it's working. Perfect. The most used endoscopic approach in literature are represented by DUS and enteroscopic assisted ERCP. So the amazing question is represented by the biliary leakage that has a range of the incidence of 3.28% in the literature, where in literature we have a lack of data about the endoscopic approach. So nobody dedicates time for this kind of complication. On the contrary, as regards the pancreatic fistula, that has an incidence that ranges from 10 to 20% in literature, the most used approach is represented by the EOS. What we can do, firstly, if we don't have a fluid collection, the first indication is to perform a pancreaticojejunostomy, leaving in place a plastic stent. If we have a fluid collection, it could be possible also to drain the fluid collection without draining the main PD. This is an example of fistula after pancreaticoduodenectomy, where we left in place an 8.5 French stent with the tip outside the pancreatic stump to collect the fluid outside the gland. As you can see in literature, we have a mix of operations that develop fistula, and these are 4 papers where they describe the approach, US approach in the setting